Very good evening to all of you. Myself, Dr. Ramyasri, I teach obstetrics and gynecology. So I hope you have all done wonderful in your exam in the December 2020 FMGE exam. Very good evening, Aniket. And I think we had a wonderful paper of obstetrics and gynecology. You had so many questions, and most of the things what we have discussed, I think almost all questions were something which we have discussed. And I think the just before day in our YouTube session, I think 2 to 3 questions were completely direct. Whatever we have discussed has come in the exam. So always OBG is a very scoring subject. So this class is beneficial for all those students who have already given the exam and all those students who are going to give the exam, because there is always many repeats. You always have repeats, and OBG should be always made as your strong subject, because you get 30 questions, some 30 around questions where you can almost score 25 to 28. So that's a very good score, right? Okay, let's start with the session and discuss all the questions pertaining to the exam, right? So let's see the first question. A woman with secondary amenorrhea with history of curettage for abortion and FSH is 7 micro international units per ml. What might be the reason for this, right? So first and foremost, the FSH level. There was a very similar question like this many times discussed by all of us. So this is a repeat question, repeat of your, I think it's a AIMS repeat question. So here if you observe, she is having secondary amenorrhea, right? And the FSH level is 7. So FSH level 7. So you should know what is the normal FSH level in order to answer this question. So the normal FSH level is 5 to 20 international units per liter. The normal FSH level is 5 to 20 international units per liter. Whenever you have FSH low, that is less than 5, it means the FSH is not being secreted from the pituitary or hypothalamus, right? So less than 5 is suggestive of hypogonadotrophic hypogonadism, whereas more than 20 is suggestive of hypergonadotrophic hypogonadism. What do I mean by that? So when FSH is very high, normally what happens is FSH is controlled by, FSH stimulates estrogen, granulosa cells to produce estrogen. But whenever estrogen levels are high, what does this estrogen do? It causes negative feedback on FSH. So FSH will automatically decrease again. But when you don't have estrogen and when you don't have negative feedback inhibition, FSH levels will become very high. FSH levels will become very high, right? So FSH levels increased is the hypergonadotrophic hypogonadism. FSH levels increased is hypergonadotrophic hypogonadism. That is, it is an ovarian failure. Because of that, there is no negative feedback and FSH level is increasing. So if I go back here, this FSH 7 comes in the range of normal. Now, if it is a pituitary failure matlab hypogonadotrophic hypogonadism. So FSH should be less than 5. So this cannot be pituitary failure. If it is ovarian failure mein FSH should be too high. It should be more than 40. Premature ovarian failure is when FSH levels are more than 40, 6 weeks apart. So it cannot be ovarian failure also. Uterine cynicae. So this can be a uterine cynicae because FSH levels are normal. Another thing which is telling that this can be a uterine cynicae is there is a history of curettage. Whenever there is damage to the stratum basal layer, so you normally have basal and this will be generating the superficialis layer. Superficialis layer is the one which sheds during every menstrual cycle. and the basal is the one which is regenerating and giving rise to the superficialis layer. But if you don't have, if there is a trauma and this basal layer is only damaged, so it will not regenerate the superficialis. And what happens? The anterior and posterior walls will get adherent to each other. And that is called as uterine synecdoche, or what is the syndrome name? Asherman syndrome. We call it as Asherman syndrome. The main reason for Asherman syndrome is repeated curetages or overzealous curetages. Mainly postpartum curettage is a very important risk factor for the uterine synecdoche. And once they have the adhesions, obviously there is no regeneration of the endometrium, so they will present you with amenorrhea. How do you investigate this? The investigation of choice is hysteroscopy. As well, gold standard is hysteroscopy. Treatment is hysteroscopic DNC. And hysteroscopic adhesiolysis. So you will break all the adhesions. So that is hysteroscopic adhesiolysis. And once you break all these adhesions, you will insert a copper T to prevent the readhesion formation. And then you will give estrogen plus progesterone for regeneration of the endometrium. So amenorrhea is a very important topic. Every exam, you tend to get 1 or 2 questions from the amenorrhea topic. So guys, you should always be perfect with amenorrhea. In amenorrheas also, commonly asked questions are in secondary amenorrhea, either for Asherman's. See, we should learn through these question papers where all we should concentrate more when we are preparing for our future exams. So amenorrhea may mainly this Asherman, Sheehan, that is pertaining to the PCOS. These are few common secondary amenorrhea they'll ask. Primary amenorrhea mein, they'll ask you that all 4 syndromes, Turner's, Imperforate hymen, AIS, Swayers, MRKH. This should be these topics of amenorrhea. In amenorrhea also I told you what are important. This should be tongue tip. Anything they ask you from here, 100% you should get that mark. Okay. So amenorrhea is a very important topic. So what we have got in the exam was Asherman syndrome, that is uterine synecdoche. So mainly you have because of the history of curettage. Is there any disease which can, any infection which can cause uterine synecdoche? Aniket, do you know any infection which can cause uterine synecdoche? Even tuberculosis can cause uterine synecdoche, right? Okay, let's go to the next question now. A woman after hysterectomy shown with distended abdomen. What's the electrolyte imbalance seen in her? Post-surgery, the distended abdomen can be due to 2 reasons. One, it can be due to paralytic ileus. Second differential diagnosis which I have for the distended abdomen post-surgery is intestinal obstruction. Now this question is not something new because we had this question in NEET 2020, post-abdomen, post-surgery abdomen, that was post-LSCS abdominal distension. So any surgery, post-surgery, you can have abdominal distension. It can be either paralytic ileus or intestinal obstruction. How do you differentiate whether it is intestinal obstruction or paralytic ileus is a very important point. Usually intestinal obstruction is because of the intra-pelvic or intra-abdominal adhesion formation post-surgery. So that adhesion formation takes around 5 to 7 days. But paralytic ileus is very immediate. Post-surgery, immediately you'll find. So this is due to the handling of the bowels, and it is also due to electrolyte imbalance, right? Intestinal obstructions is because of the adhesion formation. And which electrolyte imbalance can cause this paralytic ileus? So the electrolyte imbalance which can cause this paralytic ileus is hypokalemia. It's the hypokalemia. Hypokalemia can lead to paralytic ileus. So what happens here, as the name itself is telling, ileus is paralyzed. So it's not ready to move at all, right? So the ileus is paralytic. So because of that, what happens? There will be distended abdomen. It's not moving. How will the food go inside? How will the food go down? It won't go down. So it will come out from up itself. So they'll have nausea, vomiting. When the bowels are not moving, obviously you'll have absent bowel sounds. So there will be abdominal pain and distension, absent bowel sounds, and nausea and vomiting. Right? Whereas for intestinal obstruction, it is usually seen day 5 to day 7. Day 5 to day 7 post surgery. Now here, there is an obstruction. Beyond the obstruction, there won't be any particles, food particles going. But before the obstruction, the bowel is trying hard to push everything down. So the bowel sounds are increased. The bowel sounds are increased, right? Next thing is that in intestinal obstruction, you'll have colicky pain. This is a dull aching pain, whereas the obstruction may you'll have colicky, intermittent colicky pain. So you can see here, intermittent colicky pain with long free intervals, whereas paralytic ileus, mild dull aching pain or distension. Shock, the patient can be in shock in mild but moderate shock in paralytic ileus. Next, on palpation, there can be tenderness, especially wherever wherever there is an obstruction. Paralytic ileus, very mild tenderness or no tenderness. You will have hyperperistalsis here because of the bowels are trying to push everything inside. So you'll have hyperperistalsis. Here you'll have silent or dead abdomen. It's paralyzed abdomen, right? When you put the nasogastric suction, it relieves the pain, right? This will relieve the distension. So these are some of the differences which you have. Now, how do you treat this paralytic ileus? So it is because of hypokalemia, you can give some fluids which contain the potassium. Can you name some fluids which can contain the potassium? So paralytic ileus is self-limiting. So most of the time with correction of the hypokalemia, it becomes normal. So what you can do is you can give a RL. So you have to put the patient complete nil per oral. You put the patient nil per oral, then give her RL, IV RL. Once the bowel sounds written back, then you can start her back on the soft diet followed by normal diet, right? So you have to wait till bowel sounds written. Okay. So that's about this question. So a woman after hysterectomy shows distended abdomen. What electrolyte imbalance seen in her? It is hypokalemia. Not only post hysterectomy, post LSCS also you can see this. Post any surgeries you can see this. Okay. Right. This was the next image. So this image, you're seeing two twins. It's definitely twins, right? This is not conjoined twins because babies are not joined. So that's gone. That option is gone. Is it MCMA? No. MCMA, monochorionic monoamniotic, you should not have intervening membrane. So it is not MCMA also. Can it be MCDA or DCDA? Now that's the biggest question because placenta looks like one and amniotic sacs looks like two. But if you closely observe, there is an intervening separation between two amniotic sacs. When you have a separation between two amniotic sacs, see, can you see the third layer here? The third layer which you're seeing is the chorion going inside. So this is a two fused placentas which are looking like a single placenta and the intervening membrane, and you are having two amniotic sacs. So this is nothing but a dichorionic diamniotic. So post delivery, when you observe between the two placentas, the fused placentas, when you try to separate, you will see more than 3 layers. Around 4 layers you will be seeing. 2 placentas ka amnion, 2 placentas ka chorion in the intervening membrane. So if you observe, this is the monochorionic, monoamniotic, where there is no intervening membrane. Both babies are in the same amniotic sac. Both babies are in same amniotic sac. Right? So this is monochorionic, monoamniotic. Now see the next one. This single placenta, 2 amniotic sacs. Is there a separation or a partition between 2 amniotic sacs? No. So that is the main observation which you had to do. So there is no separation or a partition between 2 amniotic sacs. Unlike when you have a dichorionic, diamniotic, but a fused placenta, you will see a separation in between. You will see a separation in between. The dichorionic, diamniotic, these are 2 separate placentas and 2 separate amniotic sacs. I think this is crystal clear. But here dichorionic can be fused placenta with 2 amniotic sacs and a intervening chorion inside, right? Now, is there any other way? This is an image-based question which they have given. But normally, is there any other way by which we can determine the chorionicity and amnionicity? The very famous way of determining the chorionicity and amnionicity is by lambda sign or T sign, right? So what is this lambda sign or T sign? So this is a USG done around. So to determine the chorionicity and amnionicity, you do this USG around 11 to 13 plus 6 weeks. You do the USG around 11 to 13 plus 6 weeks. And when you do the USG around 13 plus 6 weeks, you will observe something like this. Guys, can you tell me what is this one and what is this one? Which one? This placenta looks like whose? Is it monochorionic or dichorionic? This is the lambda sign, a beautiful lambda sign, right? So lambda sign or twin peak sign is seen in dichorionic, diamniotic. So if you observe, this is the lambda sign. And this lambda sign or twin peak sign is seen in dichorionic, diamniotic. So the first picture which you're observing is dichorionic, diamniotic. Let's see the second picture. Second picture, if you're observing, is like a single placenta and the intervening membrane. It looks like a T. So this is T sign. T sign is seen in monochorionic, diamniotic. Here the intervening membrane is more than 2 mm. Here the intervening membrane will be less than 2 mm. Okay. Yes, I think this was also a very good question and a very good image-based question which you had. 23-year-old with postcoital bleeding. On perspeculum, the following is seen. It bleeds on touch. What is your diagnosis? So you're seeing something is small, something is coming out from the internal os. You know, postcoital bleeding, bleeds on touch, my brain goes for CS cervix, right? But the image is not matching to the CS cervix because in CS cervix, you should see cauliflower-like growth. You have 4 cardinal signs and 4 cardinal symptoms pertaining to CS cervix. So what are the 4 cardinal signs and 4 cardinal symptoms? So the 4 cardinal symptoms are postcoital bleeding, irregular bleeding, postcoital bleeding, irregular bleeding, pelvic pain, foul smelling discharge. there will be a smelly discharge, or like what do you say, watery smelly discharge, like gun starch, rice starch. It looks like that, it smells like that. And the 4 cardinal signs are it's a hard indurated cauliflower like growth which will be fixed. It also bleeds on touch, but it's friable. Matlab, when you're trying to touch it, you'll see it like small tukre it is coming out. So it is friable. Now, does this mass match to your 4 cardinal signs? Okay, let's take it as hard, indurated, but does it look like friable or cauliflower-like growth? No. And what is the first site of CS cervix? It is a transformation zone. This is arising from inside, right? So this is nothing but the cervical polyp. This is nothing but the cervical polyp. Cervical polyp. So how do you treat this? Take a small artery forceps, hold that, twist it, it comes out. But till it is there, there will be continuous, like, postcoital bleeding and intermenstrual bleeding. But when you just hold, take it off, it's over. So it is simple to treat. I'll show you the picture of CS cervix also. This is how the CS cervix looks like. So this is a cauliflower-like growth. So this will be friable, it will bleed on touch, and it will be hard in consistency and fixed. So this is a picture of the CS cervix, in case next time they give you a CS cervix. But CS cervix can also be given as a VIA picture, visual inspection under acetic acid picture, where they can show you the white patch more predominantly, right? Next question. A 22-year-old asking for an emergency contraception within 8 hours of sexual assault. She is on 13th day of cycle. What is the suitable emergency contraception? By question, my mind is thinking I need some emergency contraception which can stop the ovulation, right? Which can stop either ovulation or fertilization. That is what my mind is interpreting. So here, LNG tablet, single dose, DMPA, OCP from day 1 of the next cycle, misoprostol. They're asking emergency contraception. Now, point number 1, is misoprostol an emergency contraception? Definitely no. So that's gone. Misoprostol is not at all an emergency contraception. OCP from day 1 of the cycle will help you for next cycle contraception, but why is it emergency? OCP as emergency contraception is a use-piece regimen, not from day 1 of the next cycle. So this is also gone. The options were very simple. DMPA is not an emergency contraception. I have the only one tablet now left. It is the LNG. So LNG is definitely an emergency contraception. The dose of LNG for emergency contraception is 1.5 milligrams within 72 hours of the unprotected intercourse. Within 72 hours of unprotected intercourse, right? Hello. So that is that's about the emergency contraception. So regarding the emergency contraception, most of your emergency contraceptions can help you to stop the ovulation and fertilization. But let me quickly go speak few words about the emergency contraception. Okay. Most effective emergency contraception is IUCD, and that too in IUCDs you can take only copper T for emergency contraception. You cannot take LNG IUCD for emergency contraception. This is a very, very, very important point. LNG IUCD cannot be taken for emergency contraception. It is only the copper T which can be taken for the emergency contraception. So most effective emergency contraception is copper T, which can be given within 120 hours. Second most effective is unipristol acetate, The dose of ulipristal acetate as an emergency contraception is 30 milligrams single dose within 120 hours. It's a selective progesterone receptor modulator. Third rank is shared by two drugs, that is LNG, which is 1.5 milligrams within 72 hours, or you can also give RU486. RU486 is nothing but the mifepristone. Mifepristone dose for emergency contraception was asked as an MCQ in December 2019 question paper. So it is 600 milligrams within 72 hours. Actually, recently WHO releases even 10 milligrams is as effective as 600. But anyway, go with your standard 600. So these are like the hero type emergency contraceptive drugs. Some extra players are USP's regimen, where you give high dose of OCPs. So it is associated with nausea and vomiting. Okay, high dose OCPs. Next, you have Saheli, that is centrochromin or ormelexifene. Dose of this is 50 milligrams. So all this is within 72 hours. So only two drugs you can give within 120 hours. That is copper T and ulipristal acetate. Rest all are within 72 hours. Okay. Next. Another contraception from contraceptive. Another question from contraceptive. So second important topic for your preparation is contraceptive. From past 2-3 years, every exam you're getting got at least 2 to 3 questions. So this exam also you got almost 2 to 3 questions from contraceptive chapter. So fair enough, amenorrhea, contraceptive, perfect you should be. So what is this which you're seeing here? There's a small microcoil which is going inside the fallopian tube. There's a small microcoil which is going inside the fallopian tube. So what is this? This is called as Essure. This is called as Essure. So this Essure may, what is the mode of insertion of the following contraceptive is what they're asking. So what is the mode of insertion? This is a hysteroscopic tubal ligation. This procedure is hysteroscopic. So you take a small microcoil and through hysteroscope, you pass it to the fallopian tube. You pass into the both fallopian tubes. And once you pass into both fallopian tubes, what happens is there will be formation of adhesions. And this entire tubes will get blocked. There will be formation of adhesions and this entire tubes will get blocked. It takes around 3 months for these tubes to get blocked completely. So until 3 months, you should use some other barrier contraceptives. So it takes around 3 months for these tubes to get blocked completely. So until 3 months, you have to use some other additional contraceptives. Okay. So Essure, it is a microcoil or spring-like device you will insert. So you are going to insert through hysteroscope. It takes around 3 months for the scar tissue to grow and plug and block the entire fallopian tube. So this Essure is made up of, this coil is made up of what is also asked as an MCQ many times. It is made up of nickel and titanium alloy. Can you reverse this Essure? You cannot reverse it. It is a permanent procedure. You cannot reverse it. It is a permanent procedure. Next question. A 30-year-old female came for regular checkup found with 6 into 6 centimeters ovarian cyst. What is your next step in the management? Guys, if you remember exact formation we did in the, just before going to exam, we did this question and I was surprised that exactly it came in your, again in the exam karke. So I hope you have all done this question correct. So 30-year-old female came for regular checkup and they found a 6 into 6 centimeters ovarian cyst. And they're asking, what is your next step in the management? So first and foremost, the age is 30 years. 30 years, do you expect her to have any epithelial ovarian cancers? Absolutely no. 30 years is unlikely for them to go for epithelial ovarian cancers. Because when do we have epithelial ovarian cancers? Epithelial ovarian cancers are usually seen after the age of 45 years. So this cannot be an epithelial ovarian cancers. So CA 125 follow-up is not appropriate. Right. Now, next options. So I always teach you one table. So whenever you have a patient who is reproductive age group or perimenopausal age group, if she has an ovarian cyst of less than 5 centimeters, then you will go for wait and watch and follow up. Most of the time it will regress by itself. If you have an ovarian cyst of 5 to 7 centimeters, if it is a simple cyst, again you can do wait and watch and follow up. If it is more than 7 centimeters, you have to go for surgery. If it is more than 7 centimeters, you have to go for surgery. As well, if it is in the size between 5 to 7 and it is a complex cyst, then also you have to go for a surgery. Actually, one more point which students told me is they have mentioned it as a uniloculated 6 into 6 centimeter cyst. Uniloculated means it is a simple cyst. So simple cyst, you can wait, follow up for its regression. Evidence-wise, combined OCPs are not beneficial, but many people give 3 cycles of OCPs whenever there is an ovarian cyst. But evidence doesn't support it, but usually they give combined OCPs for 3 cycles and you have to follow up for the regression of the cyst because it is a uniloculated and a simple cyst. If you have a complex cyst, then you have to go for a surgery. If you have a complex cyst, then definitely for surgery. So as it is a simple cyst, you are going to go for combined OCP and follow-up, right? So that is regarding this question. Let's see the next question. A patient underwent oral glucose tolerance test at 27 weeks of gestation. Her fasting blood glucose was 130 milligram per deciliter and 2 hours blood glucose was 200 milligram per deciliter. Her AFI is 14. What is your next step in the management? Now, actually, one of the things which is missing in this question is they didn't mention whether it is 100 grams GTT or 75 grams GTT. But anyway, if it is 100 or 75, it is definitely abnormal values. So the values are 100% abnormal, right? Now let's speak what is OGTT. So when you use 75 grams OGTT, that is in the fasting state, when the woman comes with a prior day 8 hours of fasting, you take fasting blood sample. After giving 75 grams of glucose, you will take 1 hour, 2 hours. If it's 100 grams OGTT, prior day fasting, then you will, when she comes to you, fasting you will take, fasting blood glucose you will take, and then you will give 100 grams of glucose in around 300 to 350 ml of water, and then you will take the blood sugars again at 1 hour, 2 hours, 3 hours, right? So what is the normal values we'll see? Fasting 1 hour, 2 hour, fasting 1 hour, 2 hours, and 3 hours. Fasting should be less than 90 to 1 hour should be less than 180. 2 hours should be less than 153. 100 grams OGTT, it is fasting less than 95. 1 hour less than 180. 2 hours less than 155. 3 hours, at third hour, it should be less than 140. If you have more than 2 values abnormal, you call it as GDM. If you have 1 value abnormal, you call it as GDM here. Okay. Now go back and check your question. Your question may fasting was somewhere around 136 and 2 hours was somewhere around 200. 100% it is completely abnormal, right? And here, normally when you have a GDM with borderline glucose, you give her 2 weeks of medical nutrition therapy. That is, you will ask her to do some exercise and diet modification, and then we'll check the blood sugars after 2 weeks to see whether they have become normal or not. But here the sugars are completely deranged. So I'm not going to waste time here and I'll start her on insulin. Now I have the option, no point in repeating OGTT. Start insulin and call her again monthly. No, to start her on insulin, I should know how much dose I have to keep. I should neither keep more dose, I should neither keep less dose. I should keep an adequate dose where the sugar level, she's not going into any hypoglycemia, right? So for that, I'll admit her and start the insulin, and I'll monitor how her sugars are getting controlled with the dose of insulin I'm giving. So what we do is, normally post admission, we do 7-pint profile, where I will check the sugars at fasting state, pre-breakfast and post-breakfast, pre and post all meals, pre-lunch, post-lunch, pre-dinner, post-dinner. And I will use usually regular insulin, before breakfast. After giving insulin, immediately give her some food within 20 minutes and then check the post-breakfast sugars, whether that insulin is being enough for her or not. Then once I understand how much is the insulin requirement for her, I will keep a fixed dose and I'll send her home. And I'll ask her to check even at house also they can monitor that pre-7-pint profile. Otherwise, at least weekly once they can get the reports and show to us. So that will be what we will be doing. So admit her and start the insulin. Admit her and start the insulin, right? Another contraceptive question. What is this? So it's a copper T. Contraindication for copper T insertion. I don't remember all options, but definitely the answer students told was absolutely correct. The contraindication for copper T is PID. Any intrauterine problems, you won't insert a copper T. Any intrauterine problems, you'll never insert a copper T. So contraindication for copper T is PID is absolutely correct. So you can use the mnemonic of please don't use contraceptive. P में PID, tuberculosis, puerperium beyond 48 hours to 4 weeks, pregnancy, post-abortal sepsis, puerperal sepsis. So all these are like infections present, so you're not using. Don't make distorted uterus. So where all do you have distorted uterus? Fibroid, uterine anomalies. Fibroids which are distorting the uterus and uterine anomalies. Use unexplained vaginal bleeding. C, cancers. So you cannot use it in CA cervix. You cannot use it in GTN, gestational trophoblastic neoplasia. And for your LNG IUCD, additional contraindications are breast and ovarian cancer. Breast and ovarian cancer. Basic funda is very simple. Yeah. Agar anything is there inside, mano there's some problem already inside the uterus. How can you insert something else and increase the problem? That's the basic funda. See, everywhere you should try to understand what is that main basic thing. कि क्या बोलना चाह रहे हैं. Then when you understand that, no, it is like a cakewalk. Here already there is some problem inside the uterus. Why do you want to insert something else? Right? So this is again a grace mark, I think. So I think all of you have done this question correct. Before reading the question also, just by the image, I think you're all aware that they're showing the tense bulging hymen. So this tense bulging hymen is seen mainly in the imperforate hymen or the cryptomenorrhea. In cryptomenorrhea, where the reason for cryptomenorrhea here is imperforate hymen. So another thing supporting your imperforate hymen here was 14-year-old presenting with cyclical abdominal pain and not attained menarche yet. So a patient with imperforate hymen, they'll not present to you with, they'll not have menstruation, so they will have primary amenorrhea. Every month, when menstrual blood is getting collected in shedding, that will cause her cyclical pain abdomen. Sometimes they can also present to you with retention of urine. So this, the blood getting accumulated in the vagina is called as hematocolpus. Then the blood will go into the uterus, that is called hematometra. Then it will go into the tube where you call it as hematosalpinx. Then if you don't wait, many times when I ask if blood will further go inside, it will fall in the peritoneum. What is that called as? Many times students tell it as hemoperitoneum, but it is not hemoperitoneum. When menstrual blood goes outside the uterus, what do you call that as? Menstrual blood going outside the uterus is called as endometriosis. It's called as endometriosis, right? So this hematocolpus can compress the urethra and cause retention of urine. This hematocolpus can compress the urethra and cause retention of urine. Okay. What about the secondary sexual characteristics? In these patients, secondary sexual characteristics are normal. Gonads, ovaries are normal. It is like a false primary amenorrhea. It is a false primary amenorrhea. Sab kuch normal. HPO axis normal, uterus normal. Only the outflow is not opening. The last opening is closed, right? So what should you do here? You have to make an X-shaped incision. You have to make a X-shaped incision. And you cannot do PV. You can do a rectal examination to feel the uterus. And when you pet the X-shaped incision, there will be a flow of this blood accumulated and she'll become perfectly normal, right? Same thing. Next. Patient presents with mild spotting per vagina. On USG, gestational sac is seen without fetal node. Now this question, as per this much what I got, this tends to tell me that the answer is missed abortion. So when there is a gestational sac but no fetal node and there is a mild bleeding, obviously it can be a missed abortion. But this question also requires me to know at how many weeks she presented with this and what was the sac diameter. To call it as a missed abortion, the appropriate sac size should be sac size more than, how much guys? Sac size more than, sac size more than, sorry, mean sac diameter more than 52 mm with, sorry, more than 25 mm with no fetal pole, you call it as a missed abortion. Or when crown rump length is more than 7 mm with no FHR, you call it as a missed abortion, right? So that's the most ideal way of telling it as a missed abortion. But as per this much history, I think they're asking you about the missed abortion. Next. So till now we understood the topics which were important were amenorrhea, then contraception, and then you see there are abortion questions. So abortion and MTP is also one important topic, guys. Okay. 40 cc fetal material was detected on USG. We planned for evacuation, but the catheter goes deep into the uterus without resistance. What should be your next step? So you're seeing something is there inside the uterus and you have planned for removal of it. But when you went for removal, your evacuation catheter, so probably it's the Carmen's cannula or something, or uterine curette, it went deep inside without any resistance. So what are they indirectly telling you? That they have perforated the uterus. Deep inside without resistance means perforation. When you have a perforation with the catheter, with cannula or with curettage, or during the procedure of evacuation, it means that there is a significant perforation. So you cannot continue or you cannot wait and watch, and there's no point in mifepristone. You have to do immediate laparoscopy. You have to do immediate laparoscopy. Okay. So whenever you have a perforation with Carmen's cannula, or whenever you have a perforation with uterine curette, or you have a perforation with ovum forceps, immediate laparoscopy to be done before she lands up in hemoperitoneum. True conjugate is, guys, I think just before the day of exam, I have done a YouTube session. In that, I have tried to discuss all the images, and we have also discussed about this conjugate, right? So true conjugate, my mnemonic for you to remember the conjugates is, it's the dot. Below to upwards, dot. You can remember them as dot from below upwards. So diagonal conjugate is from lower border of pubic symphysis to sacral promontory. Obstetric conjugate is from posterior surface of pubic symphysis to sacral promontory. True conjugate is from upper border of pubic symphysis to sacral promontory. So remember, this way it will be very easy for you to answer in your exam. So नीचे से ऊपर dot. So diagonal matlab lower border of pubic symphysis to sacral promontory. Obstetric conjugate matlab posterior surface of pubic symphysis to sacral promontory. True conjugate means upper surface of pubic symphysis to sacral promontory. So if you go here, so true conjugate is upper border of pubic symphysis to sacral promontory, right? Simple. So नीचे से ऊपर dot. Okay. Yes. So Leopold manuals was also something which we discussed and then immediately got in the question. So they asked you the third Leopold manual, right? So always you should be perfect with the Leopold manuals. In INE CET, they asked second Leopold manual. In FMGE exam, they've asked third. So there can be a chance of repeat, right? So the first Leopold maneuver is called, so I'll quickly go through this Leopold maneuvers. The first Leopold maneuver is also called as fundal grip. Fundal grip, right? Where it's to know what is the presentation. So whatever is felt in the fundus vulta will be the presentation, right? So if you feel there is a soft, broad, irregular structure, then what you're feeling is the buttocks. If you palpate, there is a hard, globular, and curved and ballotable, then it's the head of the fetus. So the first Leopold maneuver is the fundal grip. The second Leopold maneuver, your hand is going slightly laterally, right? First, you're palpating the fundus. Second, your hands are going laterally. So in the second Leopold maneuver, it is also called as lateral grip or umbilical grip. You try to palpate what is present in the laterally. So if you feel there is a smooth curvy linear structure, then it is your spine, the fetal spine. Smooth curvy linear fetal spine. Multiple knob-like structures is the fetal limbs. Multiple knob-like structures is limbs. Okay. Next, third Leopold maneuver is also called as Pollock's grip. Here to confirm the presentation. Again, the same hard, curved and globular head. If you feel there is some soft, broad, irregular, non-ballotable, then it is a breech. Fourth Leopold maneuver is also called as pelvic grip. It helps us to tell whether the presenting part is engaged or not engaged, and what is the attitude of the presenting part by measuring the sinciput and occiput. Okay, so the fourth Leopold maneuver is also called as pelvic grip. If your hands are diverging, then the presenting part is engaged. If your hands are converging, then the presenting part is not engaged. And please remember how not to confuse between third and fourth is all first three are by seeing the patient's face. Only the last Leopold maneuver is by seeing the patient's feet. That's one way how I avoid confusion between all the three and the fourth one. Fourth one is the only one, the pelvic grip is the only one where you're seeing the patient's feet. What is this? So we had some direct images, so we'll go through those now. So this where you have a pouch like, this is nothing but the bilateral hydrosalpinx. Bilateral hydrosalpinx. Tobacco pouch like appearance or sausage shaped appearance is bilateral. That's the hydrosalpinx. This is, I think, the favorite of students, right? So this is nothing but the snowstorm appearance. And where do we see this snowstorm appearance? Snowstorm appearance is seen in molar pregnancy. Snowstorm appearance is seen in molar pregnancy. What is this? Where you have a pearl of chain appearance. The one which here we are seeing the pearl of chain appearance is nothing but the PCOS. So I think these were some direct images which we practiced regularly, we saw here. Next question which we had was, most dependent part in a sitting female is. So obviously when a female is sitting, the most dependent part will come for a pouch of Douglas. Pouch of Douglas, right? Next, a nulliparous patient presents with infertility. On examination, there is a fixed retroverted uterus with tender mass palpable in pouch of Douglas. The diagnosis is, now, tender mass in the pouch of Douglas, but a retroverted, fixed retroverted uterus. Adenomyosis may, you will have huge uterus of around 12 to 14 weeks, but not retroverted. Fibroid, if it is a posterior cervical fibroid, probably the uterus can go retroverted, but it won't be tender. Fibroid is never tender unless there is a degeneration, right? Now, another features which are telling that this can be, so this goes in favor of endometriosis because it is fulfilling your triad. So in endometriosis, the triad signs are, you will have firm fixed retroverted uterus. Because of the adhesions, the uterus gets pulled back and it is fixed. Then you will have firm fixed adnexal mass. And there can be a tenderness in pouch of Douglas and tender bluish nodules in the pouch of Douglas because of the infiltration of the rectovaginal septum. So it is more favorable for your, these all points are more favorable for you to answer that. This, what you're seeing here is the endometriosis, right? Yeah, so we had one more question where they asked, patient presents in labor, on per vaginal examination, cervix is 5 centimeters dilated and fully effaced. Which stage of labor she is in? I really tell that you should have not gone in this wrong, but I see some of them have gone wrong. So if you remember, every time in class I'll tell you, according to Williams, the recent guidelines of Williams, 0 to 5 centimeters is latent phase, whereas 6 to 10 centimeters is active phase. According to Williams' 25th edition, it's very clearly given that 0 to 5 centimeters is latent, 6 to 10 centimeters is active. I have so most recently, a consensus committee of ACOG, American College of Obstetrics and Gynaecology, and Society of Maternal Fetal Medicine has redefined active labor to begin from 6 centimeters. So if it is 5 centimeters, so obviously what is it going for? It's going for a latent phase. So 5 centimeters goes for a latent phase, whereas 6 to 10 goes for a active phase. Okay. Next, a woman who is lactating comes to the OPD 6 months after delivery for checkup and to get advice for contraception. She still wants to continue breastfeeding for her child, which is not to be advised. So which postcoital So when a patient, so she has come after 6 months, but the patient wants to continue to breastfeed. So when a patient is actively breastfeeding, which contraceptive should not be given? Now, POP is a lactational pill. Mini pill and POP are same. It's a lactational pill. Can you give IUCD after 6 months? IUCD can be inserted after 6 weeks itself. Here the patient has come to you at 6 months. So definitely you can give after 6 months. OCPs can be given after 6 months, but as she want to continue to the breastfeed, OCPs decrease the amount of breastfeeding, decrease the amount of breast milk. So the best answer here is the OCP. So combined OCP will be not advised to her. Combined OCP will not be advised to her. Now, normally IUCD can be inserted within 48 hours. 48 hours to 4 weeks. It's a relative contraindication. 4 to 6 weeks, it's an absolute contraindication. 4 to 6 weeks is absolute contraindication. Okay. One more question we had was, a 14-year-old girl presented with heavy bleeding per vaginum for last 10 days. What should be done to know the cause other than pregnancy test? So reproductive, even a teenage girl also you have to do the UPT and rule out, because if they're sexually active, even the first cycle, they can get pregnant. Now she is having heavy bleeding. So apart from pregnancy, what are the other reasons why they'll have heavy bleeding? So one of the reasons why they'll have heavy bleeding can be because of anovulatory cycles. Most of the time after we attain menarche, it takes almost 3 months for our cycles to regularize. So probably it is an anovulatory cycles, but in spite of that, I have to rule out something before I tell this is an anovulatory cycle which is causing heavy bleeding. So whenever you have a teenage or just attained menarche girl coming to you with heavy bleeding, always rule out bleeding and coagulation disorders. So you have to rule out bleeding and coagulation disorders. You have to rule out bleeding and coagulation disorders. So the best answer you have here is coagulation test, right? So those were the questions which you had pertaining to the obstetrics and gynecology with respect to the FMG 2020 discussion. So the important topics, I think now you have understood that amenorrhea, contraception, abortions, MTP, fibroid and endometriosis definitely something which is important. So those are like, must to read. Even CS cervix is a must to read topic. So we covered all those, and I think it was a beautiful paper where I'm very sure that all of you will score beyond 200, and all my prayers with you all for your good results. So, see you back again with the next series of obstetrics and gynecology, where I'll be discussing clinical based MCQs to you all through the YouTube. So, good night, guys. Thank you. All the best. Keep studying.